Good morning. My name is Esteban Solari, and I'm going to talk about my work on PSMA PET and MR radiomics for prostate cancer staging. This is a joint work between Clinical Research ISAR at the Technical University of Munich and the Latin Laboratory at the University of Brest. Prostate cancer is the second most prevalent type of cancer in men in the world. The diagnosis is made only with an image-guided biopsy. This biopsy is guided by an ultrasound probe, but it can be aided also with multiparametric magnetic resonance images. For some patients, it is also useful to use a PSMA PET to further delineate the tumor. The most common prostate cancer gradient system for primary tumors is the Gleason score. This gradient system is based on the radical prostatectomy and is usually used as a proxy for aggressiveness of the tumor. Typically, their values range from 6 to 10, 6 being a low Gleason score and a well-differentiated tissue, and 10 being a poorly differentiated tissue, normally from an aggressive cancer or a cancer that is already evolved. This is a tool that is used in the decision-making process of the doctor. They will decide the therapy of the patient based on these kinds of scores. The Gleason score can also be acquired from the biopsy, but the Gleason score from the biopsy tends to underestimate the score. So if eventually the patient undergoes a radical prostatectomy, that is a normal treatment for most of the prostate cancer patients, then it's likely that this Gleason score is going to change. This raises a question: is there a possibility that we can predict radical prostatectomy Gleason score from the first images that we acquire, and perhaps with some extra clinical data? To tackle this question, we started in a previous work proving that it's possible to predict up to a certain point the Gleason score from MRI radiomics. And now we want to see if adding PSMA PET radiomics will make the results better. A normal workflow for radiomics starts with an image, and we perform a segmentation in that image. The segmentation is done on the region of interest. In this case, it could be a tumor inside the prostate or the entire prostate. And we extract features from these ROIs. These features are called radiomics, but they are simply statistics. Some of these statistics include the normal clinical statistics like SUV mean, but there are some other first-order statistics. Also, there are some shape statistics that has to do with the shape of the tumor, like the volume. Finally, there are textural statistics. These features are normally correlated to the variability of the image and the texture of the tumor. With all of these statistics or features, we're going to try to predict a relevant score, in this case the Gleason score. So we started with 117 patients, but after a selection process, only 101 patients remained. Our cohort is an unbalanced cohort. That means that there's one class, in this case the class of the Gleason scores of 7 or below, that has most of the patients, in this case 60% of the patients. These unbalanced classes should be taken care in the processing. For the radiomics extraction, we use two different strategies. One for the MR images, where we segmented manually the whole prostate, and one for the Gallium-68 PSMA PET images that we segmented with a semi-automatic tool, a fuzzy locally adaptive Bayesian tool from the University of Brest. All of these features that we extracted are IBSI compliant. So we already extracted the features, and now we want to predict the Gleason scores. And for that, we're going to use a support vector machine. This is a machine learning algorithm, so we need to split our cohort in a training and an evaluation cohort. The training cohort will consist of 80% of the original patients, plus some extra patients that we're going to add as an oversampling method to compensate for these unbalanced classes that we have. With this extended training cohort, we're going to train our support vector machine model, and with the trained model, we're going to predict the Gleason scores of the evaluation cohort. After we predict the evaluation patients, we're going to switch these evaluation patients to the training part, and we're going to take another 20 patients for the evaluation. And we're going to repeat this cycle 5 times, and the results of the entire study are going to be the average of the 5 cycles. The results are expressed basically with the valence accuracy. This is a type of accuracy that takes into account not only the overall accuracy, but specifically the accuracy of every one of the classes. This is the best way to do it when you have an unbalanced dataset, as we do. We can see here that if we only use radiomics from one image, either PET or MR, the T2-weighted image radiomics are the ones that predicts Gleason scores the best. In this case, 75% accuracy. But if we combine PET and MR radiomics, we can see that we can go up to 79% accuracy. Other important results are sensitivity and specificity. In this case, we are only going to point out one particularity, and that is that we can see here that sensitivity for PET radiomics is a lot higher in the higher classes, whilst the sensitivity for the MR images is a lot higher in the lower Gleason scores. That could be one of the reasons why adding radiomics from MR images to radiomics from PET will give us an extra classification accuracy, because they have complementary information. As a conclusion, we demonstrated that we added significant value using PSMA PET radiomics to the prediction. We slightly improved the performance of our support vector machine, and we can say also that the best combination of radiomics is the one that goes with PSMA PET radiomics and ADC radiomics. And with these remarks, I'm finished with my talk. Thank you very much for your attention. Stay safe, and I hope to see you all in Hamburg next year.